Cyril, you've been very clear about the reasons why you think doctors need to be involved in management of health services. Can you share with us what those reasons are?
Yes, well, mostly one has to be concerned about value in healthcare. There's no country in the world now that doesn't have to in some way restrict what they offer because it's unaffordable. So we need to make sure that every pound we spend gets the best possible outcomes for our patients. And so that means we need to measure outcomes, we need to know the cost, and out of that you get the value. And as it's the doctors who above all commit the resource, then they have to engage with the responsibility for obtaining value for patients. It's a very simple proposition.
Cyril, Guy's Hospital introduced clinical directorates in the late 1980s, and your paper explains that they were quite successful. Why do you think the NHS is still talking about clinicians being responsible for resources in 2011? Why isn't this mainstream practice?
I don't know, and it's slightly disappointing, and it's a measure of my failure to convince people what a good idea it was. But of course it wasn't my idea. The idea actually I got from the Johns Hopkins, where they're still doing it. And across the other countries, it's more often the case, rather than the exception, that doctors are engaged in the management of the delivery of the administration of the hospital as well as clinical services. I think the particular problem in this country, by a curious sort of paradox really, was that the first attempt to decentralise hospital management was the Conservative government's Act of 1992, Working for Patients. And that made chief executives responsible in law for making sure that they delivered their budget year on year. They didn't overspend and they didn't underspend either. And they were likely to lose their jobs if they failed to deliver on that financial imperative. Mm-hmm. I suspect that as a result, the finance director had to control the expenditure very carefully, and the financial accounts became the most important measure of a trust's success.
They did, in short, they didn't trust the doctors.
They couldn't trust the doctors because they were frightened that if there was an overspend or an underspend, that they'd lose their jobs. And so management accounts, which have been the hallmark of what we were trying to do at Guy's, were no longer important. Budgets weren't set according to them. It was only the financial accounts. But if you go into the private sector, which I do a bit nowadays, it's the management accounts and the budgets as the cash flow that determine the financial control. And I think foundation trusts, by contrast, allow organisations to create surpluses for investment, as do medical schools, which I went on to manage. And they then depend a great deal on their management account and budgets, and they decentralise. So I think it was actually an accident rather than a design, but it's very sad.
Do you think that the current way that medical education is delivered and continuing professional development is provided helps and equips doctors to take on these leadership roles?
That's an extremely complicated question. I think young people go into medicine largely because they care about their fellow human beings and they want to apply the science that they've learned to benefit patients. And I think the last thing in their mind when they go through medical school is management and health and safety at work and all those sort of issues. Mm-hmm. And certainly I tried to get them interested when I was the dean of a medical school, and I couldn't. And I said I put it in the final exam, and it didn't work. So I don't think you can actually teach management. They can learn it by observation of what they see going on around them. And of course they can learn very important social skills and team working skills in lots of other ways as they go through medical school. Now when you move to continuing professional development after they're qualified, then it's a completely different issue. They should be there by then part of teams, and those teams should be thoroughly engaged with the management of resource. And there the big problem is that you learn from following examples, not by what you're taught. And if the examples are no good, you won't learn. And so you're committed to a cycle of a failure at that point. So we've really got to put a huge amount of effort into getting senior doctors engaged.
Is there something that trusts should be doing to encourage doctors to take on leadership positions and preparing them for their roles?
Indeed they should. And it's not that difficult to do. You just have to give them a responsibility, give them the authority commensurate with that responsibility, and hold them to account. But if you don't actually give people a responsibility, you can hardly be surprised they don't engage. And the centralising tendencies of the National Health Service have mitigated against that over the last 20 years.
Your paper finishes with a list of the duties of a doctor, which are part of the GMC's requirements. To what extent do these duties drive the way that doctors behave once they're qualified?
Well, I know what I wished when I was chairman of the Standards Committee of the General Medical Council. I suppose I wished that they'd consult them every morning as they got out of bed before they went to work. But I know I never did when I was a doctor. And so I don't think that's realistic. I think it is a background, and a very important background, to the practice of a doctor. It's like the Hippocratic Oath used to be. And certainly when we qualified our doctors at the medical school, we used to have a special ceremony rather than a degree ceremony, because to my mind, that day was the first day of the rest of their life. And with their families and their friends and mums and dads there, we had them commit to the duties of a doctor, so that they'd at least remember that that day, that's what they signed up to. So in setting a standard for practice, I think it's very important.
We've been talking about culture. What do trust boards need to do to establish a collaborative culture between doctors and managers?
Engage with them. It's get around the problems of professional bureaucracies of disconnection. Make sure that the clinicians are taking management responsibility and are on the board, and make sure the board gets out into the hospital. Came up quite a bit this morning. It's the old adage, the best manure is the farmer's feet. You've got to get out.
Thank you very much, Cyril, for sharing your experiences and insights.
It is a pleasure.